Yes, sir, they have joined.
Okay, perfect. Mishra sir, shall we begin? It is
Yes,
ten
yes,
three.
please, Sushil, go ahead.
Yes, yes, yes,
Go
yes,
ahead.
yes. Smruti, go
Yes,
ahead.
Yes,
yes.
start.
So a very warm good morning to one and all. And as it is a Sunday morning, and we are here for yet another exciting, interactive, scholarly Sunday session. This is session number 5. The topic is short case presentation, exam related strategies and techniques. I, Dr. Spriti Shali Bagde, will be the moderator for this session. And to begin with, I would like to 1 second, sir. I would like to welcome Dr. K.K. Mishra, sir, the President of Psychiatric Society Western Zone. Sir, can we have few words of wisdom from you?
Yes. Thank you. Good morning, Smiti, and all the team members, including Sushil. And this has been a regular phenomenon and is one of the most active subcommittee of the West Zone, the PG subcommittee. And we are regularly having some or other program for the residents. And short care presentation is one of the important aspects. You can most of the time find students have difficulty to have a boundary, how much history they should take, and what are the things, examination aspect they should present. So I think this will be very much helpful. And Nishikant and the Naina Madam being who are the experienced teacher, they will able to develop on this, and it will be definitely beneficial for the student. With this short thing, so this short note, I welcome you all to this program and hope this will be a learning experience for all of you. Thank you very much.
Smriti,
Susan, go ahead.
you are muted.
Thank you so much, sir, for your precious time for joining with us. Now, I would like to welcome Dr. Sushil Gavande, sir, Chairperson, PG Education Committee, Western Zone. Sir, can we have few words from you for the students?
Uh, thank you, Smriti. And first of all, I'm extremely thankful to Mishra sir for taking out time to join this session, and thankful to our faculty, Dr. Naina ma'am and Nishikant, for taking their precious Sunday morning for our students. As I told ma'am and Nishikant in the messages, that this is a regular activity of PG Education Subcommittee, and every month we have some or other activity. Uh, Now the exams are there in most of the colleges. Prelims, theory exams are over, and prelims practical examinations will be there in the next week. And in the next month, final theory exams and final practical examinations will be there. So by keeping this thing in mind, we thought of arranging short case presentations in this session. The next session will be on a long case presentation. So thank you to both the faculty, President Sir, and our moderator Smruti, and all our students who are regularly joining this activity with great zeal and enthusiasm. So without a further ado, I hand over the platform to Smruti for further proceedings. Thank you so much.
Thank you so much, sir, for your kind words and motivation. And I would like to extend my huge welcome to all the esteemed faculties and all the dear students. The faculty for today's session is Dr. Nishikant Thorat, sir, and Dr. Naina Nayak, ma'am. We welcome you, sir and ma'am. Dr. Nishikant Thorat, sir, is Associate Professor and Head in the Department of Psychiatry at BJ Medical College, Pune. He is also serving as a nodal officer at Addiction Treatment Facility and Chhatra Manas Kaksha, Student Mental Health Wellbeing at BJMC, Pune. He is a principal investigator at National Mental Health Survey, Maharashtra State. Dr. Naina Nayak, ma'am, she is associate professor at Institute of Psychiatry and Human Behavior at Goa. She has total 25 years of teaching experience. She is a regular speaker and moderator at academic programs. She has also worked as a specialty doctor in psychiatry at NHS UK and holds multiple publications in national and international journals. Thank you so much, sir and ma'am. Now, I would just provide a brief template for the short case presentation and how to go about it, and then we'll hand over the mic to the presenters. So these are few of the resources. for history taking and for the diagnostic formulation and mental state examination. A book by Dr. Nitin Shetty, sir. A book on history taking and diagnostic formulation by Indian Teachers of Psychiatry Forum. And also few points are very good formulated and are presented in the book Straub and Black. So for short cases, the different cases which are kept for short case presentations, they are from the child, ADHD, autism spectrum disorder, intellectual disability with behavioral disturbances. Coming from the adult cases, schizophrenia with significant MSc findings, alcohol use disorder with withdrawal signs and symptoms, important CNS examination with MSc findings, major depressive disorder with depressive cognitions, and also with history of DSH attempt, and obsessive compulsive disorder with the typical presentation, and also with comorbid depressive features. These are few of the cases. Now, for the short case presentation, the time allotted as per different universities and also as per NMC guidelines, the case taking 30 minutes, for the presentation 15 to 20 minutes, and again followed by viva and discussion for the next 20 minutes. So there are two very important points which we keep in mind while taking case for short case presentation, that the history should be very concise, brief, and should be to the point. So the history taking doesn't have to go about here and there. And secondly, about the detailed mental status examination, and also the verbatim to be presented in the relevant subheadings such as thought, perception, judgment, insight. Now, so while taking the history, all the points should be covered, but the focus or the emphasis should be over the chief complaints and the history of presenting illness, the past psychiatric history, including the prior episodes, hospitalization, so the longitudinal part, and also the personal and family history, and the past medical or surgical illness, and the substance use history. Coming to the mental status examination, it should be covered in detail, starting from the general appearance and behavior to eye contact, psychomotor activity, coming to the speech, the spontaneity, rate, tone, volume, then coming to mood and affect all the subheadings such as lability, then intensity, range, reactivity has to be covered. Then in thought, all the four components of form, content, stream, and possession, and then perception about the deceptions and the distortions, and the cognitive areas of attention, orientation, memory, and then the insight and judgment. Coming to the physical examination, you should take the vitals, pulse, BP, temperature, and also have a general inspection of pallor, icterus, and if any tremors are present, any gait disturbances are present. Then, while formulating the diagnosis, the 4P model should be covered: the predisposing factors, precipitating factors, perpetuating, and the protective factors. And while you present the case, the history taking all the relevant and important details to be covered, the mental status examination should be covered in an order and should be very detailed, and also the relevant physical examination, then the provisional diagnosis, the differential diagnosis, and then your the proposed management plan. And then comes the discussion portion. And now I would like to introduce my presenters, Dr. Shubham Nagare. He is a junior resident second year from Indira Gandhi Government Medical College, Nagpur. And Dr. Saloni Nayak, she is also junior resident second year from Topiwala National Medical College, Mumbai. So now I would like to hand over my mic to Dr. Shubham to start with the presentation. Shubham,
Yes, ma'am.
are you there?
Yes, ma'am.
Yes.
I'm not able to share screen. As you are.
One second.
I have to stop sharing.
Yes, sir. I'm not able to remove. Can someone guide me with this?
Yogendra? Yogendra, can we make Shubham co-host? I'll give him a call, Smriti. Yeah? Just a minute.
Yes, sir. Yes, sir.
Ha. Smriti, he's co-host now. He can share.
Yes, sir. Okay, sir. Okay, sir. Thank you so much, sir.
Is it visible?
Yes, yes, it is. It is.
Yes, it is visible.
Good morning, all. I will start today's case presentation. Uh, First, my patient ABC of 35 years old male who is married, right-handed, and was educated till 7th standard, was laborer, Hindi speaking, Hindu by religion and belonging to lower socioeconomic status, resident of Takri, Nagpur. Presented with chief complaints of I have taken in, presented with chief complaints of history of fall under influence of alcohol 2 days back, followed by disturbed sleep, restlessness, tremulousness, and hearing of unreal voices since last 2 days. I have taken information from patient and his wife, which is reliable and adequate. With history of presenting illness, patient consumed his first drink when he was 14 years old, along with his friends during Holi festival. He consumed around half pint of beer and after that felt calm and relaxed. After this, he started consuming occasionally along with friends and his cousins during festivals and social gatherings for next few years. Then he started consuming alcohol more frequently, particularly on weekends, as his friends used to invite him regularly. He started having during the next few years, he started having desire for consuming alcohol regularly after coming home, and even used to finish his works early to consume alcohol. In the year 2017 to 21, initially he used to consume around 1/4 of English or country liquor, depending on the availability of finances daily, but he gradually increased the amount of consumption to 2/4 and even more over time, as he was not getting the amount of pleasure with that previous quantity of alcohol which he used to consume. During this time period, patient also started consuming alcohol alone at liquor shop and used to go to workplace sometimes intoxicated, and was constantly preoccupied with thoughts of consuming alcohol during work and even after finishing his work. After that, he observed whenever he used to abstain from consuming alcohol, be it any reason, he used to have restlessness, sweating, and tremulousness, and sometimes disturbed sleep, and which used to subside after consuming alcohol. He remembers on occasions he used to consume alcohol in large amount, even though he had planned to consume lower amount, as he lost his control over his drinking. In the year 22 to 26, he even started being irregular at his work, started drinking alcohol even in the morning, as he used to have tremulousness after waking up. He even received multiple warning from his workplace, as his wife reports, and frequent quarrel with family members, particularly wife, over his alcohol issue. But he did not stop drinking alcohol. He even had episodes of retching, pain in abdomen, loose stools, nausea and jaundice on multiple occasions, requiring hospital visits here and there, but not requiring admission. And despite clear instructions from the physician to abstain from alcohol, he continued the consumption. 2 days back, while he was returning from liquor shop to home after consuming alcohol, which was also his last drink, he had a fall and he started having pain over his right shoulder. Because of pain, he didn't go outside for consuming alcohol as well as work, and he started having palpitations, sweating, tremulousness, hearing of voices of birds chirping and whistling sound, and was not able to sleep during night also since last 2 days. So his wife brought him to hospital, and he was admitted under Department of Orthopedics. And then Department of Orthopedics sent a call for psychiatric evaluation in view of patient trying to remove IV lines, getting agitated, in view of withdrawal symptoms. There is no history of significant head injury, high-grade fever, no history of sudden onset, limb tightening, tongue bite, loss of consciousness, incontinence, or no history of hematemesis, melena, flapping tremors, no history of distension of abdomen and severe abdominal pain, no history of suspiciousness and poor self-care, and no history of pervasive low mood and loss of interest. In the past history, there is no past history of major medical or any surgical illness. Also, there is no history of complicated withdrawal in the past requiring hospitalization. In the family history, there is no history of any psychiatric illness in the family apart from history of alcohol consumption in his younger brother. In the personal history, patient started working at early age to support his family, and dropped out of school in the 7th standard and started working as a laborer at construction site. Currently, he is working as a laborer at construction site and earns around 8 to 10K per month, and spend approximately 5 to 6K on alcohol per month. In the personal history, substance use apart from alcohol, which I have explained earlier, patient denies history of any other substance abuse apart from occasional tobacco chewing. In the marital and sexual history, patient the marriage between the two was non-consanguineous in 2016, and patient has 2 children. There is also frequent quarrel over alcohol use with the family. Wife reports frequency of sexual intercourse has reduced since last 2 to 3 years. In premorbid personality, patient is socially well adjusted. Moving to physical examination, the temperature of patient was 37 degrees centigrade, pulse rate was 102 beats per minute, respiratory rate 16 breaths per minute, and the blood pressure was slightly raised, 140 by 90 millimeters of mercury. Icterus was present, tremors were present, icterus was present, no pallors, no cyanosis clubbing, No pedal edema and no lymphadenopathy was noted. The height of patient was 164 centimeter and his weight was 52 kilograms. On local examination, there was his range of movement was restricted at right shoulder joint. Moving to systemic examination, in the abdominal examination, there was no distension was noted. Umbilicus was centrally placed and inverted. No scar mark or spider nevi or dilated veins over skin of abdomen. Abdominal movement with respiration was present. Respiratory system and cardiovascular system was also within normal limit. In the examination of central nervous system, patient was not cooperative to look for cerebellar signs. Moving to mental status examination, the general appearance and behavior, and patient was an adult thin-built male, minimally cooperative and communicative, sweating profusely, shouting in ward, looking here and there, trying to remove IV lines and catheters. Patient was restrained to bed, was muttering intermittently and picking behavior established, fluctuating orientation to time and place was present, but patient was oriented to person, albeit to his wife. Eye-to-eye contact was not initiated and not maintained. Rapport could not be established. The psychomotor activity of the patient was markedly increased. Speech of the patient was non-spontaneous, irrelevant mostly, and incomprehensible sometimes, with increased tone and volume. Mood patient did not convey. Affect was perplexed and irritable. Thinking could not be assessed. Perception, there was hallucinatory behavior present in form of picking behavior and shouting. Higher mental functions could not be elicited. Social judgment of the patient was impaired and insight was absent. Summary, a 35-year-old male with no past and family history of any psychiatric illness, with history of regular and heavy consumption of liquor in dependence pattern, about 3 to 4 quarters per day since last 8 to 10 years. And the last drink was 2 days back before admission, with chief complaints of history of fall under influence, restlessness, disturbed sleep, tremors, hearing of unreal voices since last 2 days, with no past history of complicated withdrawal and any known major medical or surgical illness. On examination, raised pulse and blood pressure with tremors of hands and pain and reduced mobility over right shoulder joint, and MSC revealing fluctuating orientation to time and place, with increased markedly increased psychomotor activity, hallucinatory behavior, irrelevant talk, and perplexed affect, with impaired social judgment. So I would like to give my provisional diagnosis based on this as alcohol dependence, current use continuous, in withdrawal, and currently alcohol-induced delirium. Patient was admitted under ortho ward and psychiatric call was sent. So all baseline investigations were already sent. Vitals monitoring was also started. In the liver function test, there was total serum bilirubin was slightly raised. Also, direct serum bilirubin and liver enzymes like SGO2, SGPT were also raised. Raised markers were within normal limit. X-ray from the ortho side, X-ray shoulder was suggestive of fracture lateral end of right clavicle, and shoulder brace and analgesics and injection pantoprazole and injection ondansetron were given to patient. Medicine reference was also done from ortho side, under whose advice patient was shifted to ICU. CT head was advised, which came to be within normal limit. Also, serum amylase was also advised from medicine side, and which came to be in normal range. In the management, patient was started on injection thiamine 100 mg TDS intravenously with IV fluid, and police catheterization was done by department from medicine side. Then patient was started on symptom triggered management with benzodiazepine injection lorazepam with Chiva AR monitoring in ICU. I have mentioned here scores of Chiva AR scale, and then on the first day, injection lorazepam total 10 mg with injection haldol 2.5 mg for agitation on SOS basis was given with physical restraint was done from ortho side. On the second day, when patient was moved to ICU, the dose of injection lorazepam was kept as 10 mg over the course of 24 hours, and injection haloperidol for 2.5 mg IM for agitation was also given. From day 3, dose of injection lorazepam was decreased to 8 mg, and then on day 4 to 6 mg. After that, patient shifted to ward on 4th day and was shifted to oral lorazepam and gradually tapered off 4 mg per day and shifted to oral thiamine supplementation of 100 mg TDS. Family members of the patient regularly psychoeducated regarding course and prognosis of delirium. After withdrawal stabilization, motivation of the patient is assessed and motivational interview ongoing. I would like to start patient on tablet Acamprosate, 330 mg, 2 in the morning, 1 afternoon, and 1 in the evening, as his weight is less than 60 kg. After recovery and discharge, I would ask patient to follow up regularly in the short-term management to continue him of tablet Acamprosate, would explain the patient medical model of illness and importance of treatment, counsel him regarding avoidance of cues that may lead to his relapse. In the long-term management, I would continue him on Acamprosate, make him attend Alcohol Anonymous groups regularly, encourage him to get back to work and give positive feedback for his abstinence from alcohol. Also would assess expressed emotions if any and would address that. Also advise them to bring patient to hospital at earliest if relapse. Thank you.
Thank you, Dr. Shubham.
Smruti, please unmute yourself.
Thank you so much, Dr. Shubham. And now I would like to hand over the mic to the faculty for further question answer and the discussion. Over to you, ma'am and sir.
Hello, Shubham. You
Yes,
have presented it nicely, all the longitudinal history and current mental status examination. I would like to clarify on what was the quantity of alcohol he was recently using or consuming.
Sir, he was consuming 2 quarters of country liquor.
Okay.
Throughout 24 hours.
And was there any history of complicated withdrawal in past?
Sir, there was no history of complicated withdrawal requiring admission as such as informed by the informant. Few times the wife reported that they had visited a hospital, but there was no clear-cut history of any complicated withdrawal as such.
And what was the period of maximum abstinence in past?
Sir, maximum abstinence, there was 2 to 3 days maximum. Whenever he used to be somewhere, maximum 2 to 3 days, he never tried to stop alcohol.
And what was the reason to continue him on alcohol, from the history? Was there any stressor or is?
Sir, patient was working as a construction laborer. So after finishing his work, he used to consume alcohol daily, and then he also, whenever he used to have withdrawal features like restlessness in the morning or tremors or palpitation, he used to again consume.
Yes. So you said that he was a well-adjusted personality. Can you
Yes.
comment about his PMP, pre-morbid personality?
Sir, the informant was his wife. So before marriage, he was drinking alcohol.
Hmm.
So wife said that he has a good
Because
relation.
you also said there were frequent quarrels with the wife and because of the alcohol. So we're doubtful whether he was well-adjusted for the pre-morbid personality or because he was giving excuses. What are the defense mechanisms patients of alcohol use? Like,
Sir,
tell me.
denial is the one. Then rationalization is there. Projection.
Mhm. Yes.
And
So when you visited this patient on the orthopedic ward, what was your initial assessment of him? Like,
sir,
on the-
patient was agitated at that time and was not was disoriented actually and was restrained to bed as he was shouting in the ward. The orthopedics people had restrained him to the bed, and he was easily distractible and was shouting here and there.
so as you said, he was in delirium.
Yes, sir.
Oh. So what are the factors which lead to delirium in case of alcohol use?
Uh, sir, delirium may progress.
Like all patients of alcohol don't go into delirium, no? It's alcohol use. So I am asking what are the risk factors which enhance the chances of patient going into delirium, alcohol withdrawal delirium?
Non-treatment of withdrawal features is the one factor. Also, heavy drinking is the one, and previous non-treatment is the one, and also comorbid diseases might contribute to delirium also.
As per your diagnosis, and what according to what classification you're given the diagnosis, ICD-11 or DSM-5 TR?
Sir, I have given diagnosis based on ICD-11.
What will be the DSM-5 TR diagnosis according to DSM?
According to DSM, sir, alcohol use disorder, currently in withdrawal, and in alcohol-induced delirium.
Okay. So how will you calculate the dose of benzodiazepines required for the treatment of delirium in this case? Because you
Sir,
said you started with 10 mg of lorazepam.
yes, sir. Sir, no, sir. Over the course of 24 hours, I have mentioned, I have started on based on a symptom-triggered regimen, where I started patient on 2 mg injection until light sedation is achieved, and then continued it on second day. Sir,
How
there are,
do you use 2 mg of lorazepam? Like injection?
sir,
Does
injection
it come in 2 mg?
can be given IV or IM. So we started on IM as patient was not.
In injection lorazepam, how it is available in ampoule? Like how much quantity is there in one ampoule?
Sir, it is available 4 mg per 2 ml.
Okay.
Yes.
So if you use 2 mg, you have to discard the other ml required. Remaining.
Yes.
So what are the other modalities of treatment? Like you said, symptom triggered. What are the other?
Sir, other modality is one is front loading and other is fixed dose regime. In the front loading modality, sir, we give 10 or 20 mg upfront, and then we generally use long acting benzodiazepine, and then and in another fixed dose regimen, we 6 days regimen is used in simple, uncomplicated withdrawal mostly, as we do not alter it.
What is the half-life of lorazepam?
Sir, lorazepam is short-acting. I don't exactly.
It's not short-acting. Okay. So as you said, like, what are the chances of recovery in case of delirium in general, not in this case?
Sir, generally, sir, delirium has 20 to 30% chances of mortality. Best patient, if adequately treated, may recover with high definition unit admissions and proper diagnosis and treatment.
So as you mentioned, he was admitted in ortho ward and then he was shifted to ICU because of the delirium status. So what precautions should be taken during this phase, like till he comes out of delirium, and to prevent further complications?
Sir, first, frequent orientation to time, place, and person to be given to patient. Also, familiar objects to the patient be placed around him. Also, frequent. Also, during night time, dim lighting to be provided, and patient avoid noisy areas. Then patient to be given during night time also, we would sleep of the cycle, advise him to maintain sleep. Also,
Okay.
family to be.
Yeah. Now over to Naina madam for any further continuation.
Yeah. Thank you, Dr. Dr. Shubham, I would like to ask you a few questions from the history itself. Okay, in your negative history, you are not told about history of extramarital affair. Is there any history of extramarital affairs? Patient is to suspect his wife, any history of infidelity? And what is the reason that he drinks, like he has gone in dependence? And how long he's been married?
Ma'am is married since 10 years. Initially, he started when he had money, when he had dropped out and started working as a laborer. He started with his friends, and then after a few years, his friends used to invite him. Then, ma'am, after finishing his work, he used to consume alcohol initially with his co-workers, friends, and then he started consuming alone. Ma'am, financial condition was the one factor, and the work-related stressor, that is, he used to work as construction laborer. That was another factor to carry on the drinking. And then, ma'am, negative reinforcement in form of withdrawal features also contributed in his continuance of drinks.
So who else is there in his family? He has got children to look after?
Ma'am, his wife is there and he has 2 children.
What is the relation with them?
Ma'am, wife reported that he has frequent quarrels with her, but apart from that, he has good relations with children, but sometimes over the quarreling, due to quarreling, the relations get disturbed, but overall she described him as relations.
Okay, in your MSc, you have said about you could not interview him properly because he was looking here and there, he was hallucinating. And in your insight, you said insight is absent. So could you really assess his insight in this case?
Ma'am, in Insight, ma'am, when I asked him, I could not interview him properly, but when I asked him he had any illness or not, he said no. My wife, मतलब मेरी बीवी ने मुझे इधर लाया है, मुझे कोई बीमारी नहीं है, मुझे यहाँ से जाने दो. And he was getting agitated. That is why I have mentioned Insight as absent or grade 1.
So because see, his comprehension was poor, he was partially disoriented. So in that case, it's difficult to say Insight is present or absent. You could have
Yes.
said could not be assessed, right?
Yes.
Okay. Yeah. Then physical examination, did you check for his temperature?
Yes. Ma'am.
That part is missing about temperature.
Ma'am, the temperature reading was taken by nurse. I have also checked his abdomen, which was there was no obvious fever.
No, you need to mention because he is in delirium. So you
Yes.
need to rule out other causes of delirium also. So that is
Yes.
why it is important. Okay.
Yes.
Regarding your management, you said anti-craving. You'll start him on acamprosate. So
Yes, ma'am.
how did you choose this drug, acamprosate? Why not other medications?
Ma'am, there are two FDA-approved anti-craving agents. One is naltrexone and another is acamprosate. Ma'am, I could start acamprosate while not worrying about stopping of his drink. That is why I would start him on acamprosate. Also, depending on his current status.
Like what?
Like, ma'am, as his hepatic means, ma'am, his liver enzymes were slightly raised, but were not severely impaired.
So acamprosate is a better choice compared to naltrexone here.
Yes, ma'am.
Okay. Yeah, and you said injection thymine 100 milligram TDS. How, like injectable, you were giving IM or how you were giving this?
Ma'am, no, it was given in IV, and it was started from medicine department. Actually, I would have given 300 mg in 1 unit NS. But as medicine people have already started him, and overall 24-hour dose was given appropriately, I did not change that.
Okay. Regarding your management, you'll say like I will explain him about a medical model of treatment.
Yes, medical. Yes, ma'am.
Only the medical model of treatment in here in this case, or is overall you would
Ma'am,
like to?
Overall, I was trying to explain that I would explain him medical model of illness, that whatever current situation of delirium or the withdrawal features that he was having were also the previous histories of jaundice and all that was happening due to alcohol. These were the consequences of alcohol that I would try to explain him and build his insight towards that, and then would ask him to continue the treatment.
So how are you going to build the insight for him?
First, ma'am, in motivational interviewing, I would ask him. In the motivational interviewing, ma'am, I would allow his discrepancy to build, and then allow him to talk to change talks, and let I would roll over his resistance and then build up his insight, and also allow by explaining the medical model of illness and the symptoms that he was experiencing.
Okay, and what about his wife? What are you going to teach her, or what are you going to tell her about this?
Ma'am, I would assess whether any expressed emotions are there, and if there are any, I would address that. Next, I would also ask her to monitor him and do not criticize if anything is there, and also by monitoring him, if the signs of relapse were there, I would ask her to bring him to hospital.
Okay, thank you.
Thank you.
Now, any question from the audience? Any student want to ask something?
Smriti, we shall take second case because we are
Okay,
running
sir.
short of time. At the
Yes.
end, we will take that.
Okay, sir. So now I would like to invite Dr. Saloni Nayak, our second presenter, to present her case.
Ma'am, I am trying to share the screen. Is it visible?
It is visible.
Okay. Good morning, everyone. I would like to start the case presentation. It is a short case presentation on a case of child. Mr. A, 12-year-old male, right-handed, Hindi-English speaking, currently in 7th grade, resident of Matunga, was brought by mother who is adequate and reliable informant, with chief complaints from parents of poor attention, easily distracted by surrounding activities, unable to sit still, school complaints of poor concentration in class, mischievousness at school, poor in academics since 5 to 6 years and increased since 1 year. I would like to present the history longitudinally, starting from birth history. Patient was born out of non-consanguineous marriage, second by birth order. It was a full-term normal vaginal delivery with no history of ANC or PNC complication. The birth weight was 3.5 kg and the patient cried immediately after birth. He is vaccinated till date as per schedule with no history of NICU stay, neonatal jaundice, convulsion or cyanosis. Breastfeeding was started immediately after birth and completed by the age of 1 year. Developmental history, in gross motor milestones, crawling was started at the age of 9 months, standing without support at 12 months, fine motor, unidextrous grasp at 6 months, mature pincer at 12 months, social smile was attained at 2 months, stranger anxiety at 6 months, in language, bisyllable was started at 2 months, and patient started speaking in full sentences by 2 years. Parallel play was there by 2 years, and playing in group at school was in 4 years. Activities of daily livings were independent by 4 to 5 years. This is suggestive of age-appropriate developmental milestones. In scholastic history, patient was enrolled in school at the age of 3 years. He is in ICSE board, poor in academics, especially in maths and his handwriting. There was no failure in any grade. Currently, he is in 7th grade, and there is no history of school refusal. History of present illness, patient was apparently all right until 1st grade when parents started noticing change, that he would not pay attention when mother used to teach him at home, had poor concentration, would often seem lost when spoken directly to, would have to be called out repeatedly, would often forget tiffin, bottle, pencil case at school, would keep all his toys in disorganized manner all around the house. He was not able to sit still at one place, would run around in the house hurting himself, would often be fidgety with his hands, would interrupt parents in between conversation and had difficulty waiting for his turn in games when playing with other children. Parents would also receive frequent complaints from school that he often leaves classwork in between or rushes too much to complete it, that his handwriting becomes incomprehensible while making silly mistakes, especially in maths. He leaves classes in between, frequently going to toilet every 15 minutes, would shift benches in between class and talk to other children, disturbing them. He would often pick fight with other children and be verbally abusive towards them. All of these symptoms are present since first standard, but currently it has increased since 1 year. There is no history suggestive of difficulty reading, writing, or any spelling mistake. No history suggestive of ODD conduct or autism traits. No history suggestive of depression, mania, OCD, phobic, substance use, or any psychotic symptom. No history of head injury or seizures. No significant past history present. In family history, there is no history of psychiatric illness in the family. There is history of hypertension in father, maternal and paternal grandmother. No history of any cardiac illness in the family or a history of seizure disorder. The father works in marketing and sales, and the mother is teacher by occupation. He has an elder sister who is currently in 10th standard, and there are no learning disabilities or history of ADHD in sister. No IPR or financial stressors as such, and the parenting style by both the parents is authoritative. On examination, the BP was 100 by 60, pulse rate was 88 per minute, height was 158 centimeter, weight was 38 kg with BMI 15.2, which is appropriate for his age. There is no evidence of pallor icterus, cyanosis, clubbing, lymphadenopathy and edema, and systemic examination was also within normal limits. Temperament, the activity level was high, rhythmicity was irregular, he had good adaptability with short attention span, labile quality of mood with high distractibility, high intensity of reaction and low threshold, suggestive of difficult child. On mental status examination, patient was conscious, cooperative, communicative, well-kept, average-build male child, sitting comfortably on the chair but fidgety with his hands, courteous towards examiner with normal psychomotor activity. Eye-to-eye contact was initiated, maintained, attention was aroused and ill-sustained, rapport was established, he was oriented to time, place and person. On memory, registration was 3/3, recall was 3/3, recent and remote were intact, language function and judgment being intact. Intelligence was clinically average, as I asked him general fund of knowledge questions which was adequate for his age. He could perform simple and complex calculations, and abstraction was also intact. Mood he conveyed as okay. Affect was mood congruent, stable, normal in range and reactivity, and appropriate to the surrounding. Speech was spontaneous, coherent, relevant, with normal rate, tone, and volume. In thought, no formal thought disorder was elicited, no delusion elicited. He denied any preoccupations. He denied any perceptual abnormalities, and the insight was 4/5, since he said that he knows that he is easily distracted by surrounding activities, and he thinks that the medications might help him. So according to me, the impression was attention deficit hyperactivity disorder combined presentation with the with ICD-11 and DSM-5 TR diagnosis being the same. In summary, Mr. A, 12-year-old male right-handed, Hindi-English speaking, currently in 7th grade, resident of Matunga, brought by mother with chief complaints from parents of poor attention, unable to sit still, easily distractible since 5 to 6 years, increased since 1 year, with complaint from school that are poor academic performance, poor concentration, and mischievousness in classroom, increased since 1 year, with no significant birth and developmental history, with poor academics in mathematics and handwriting, with family history of hypertension in father, maternal and paternal grandmother, with authoritarian parenting style, with temperament suggestive of difficult child, with positive MSc findings of eye-to-eye contact initiated but not maintained, attention being ill-sustained, with clinically average intelligence and insight being 4/5, with diagnosis of attention deficit hyperactivity disorder combined presentation. In diagnostic formulation, Mr. A, 12-year-old male child, currently in 7th grade, resident of Matunga, brought by mother with persistent pattern of inattention and combination of hyperactivity and impulsivity symptoms for 5 years, that is outside the limits of normal variation expected for his age and level of intellectual development, with no predisposing, precipitating or perpetuating factor, but the protective factors being clinically average intelligence, absence of any learning disability or other psychiatric comorbidities, and supportive parenting. I had not included management in my slides, but I would like to say it orally. So first of all, after seeing that there is no family history of any cardiac illness or no history of any comorbidities in the child himself, like seizure disorder, with the BMI being appropriate for his age, I would like to start him on, I would like to treat him on OPD basis, and would like to start him on tablet methylphenidate 5 mg. Also, I would like to explain the parents regarding the course of the illness and how the treatment might help him with helping them explain the illness itself. I would also like them to make some psychosocial intervention in the form of environmental modifications in the child's environment. That there should be a structured environment. The child should follow a routine. They should give a reminder about any transition in the routine. There should be the physical environment must be structured in a way that the child should be made to sit in a room where there are no distraction. There shouldn't be other sibling in the room. There shouldn't be any devices. The books that are kept in the room should be only related to academics. The shelves should be named accordingly, with the help of some labels, so that the child keeps his books and things organized in the room. There should be adult supervision on homework, and there should be like short instructions. This message should also be conveyed to the teachers at school, so that the modifications are also made in the school itself. Every 20 minutes the child should be given a 5 minutes of break. He should be given some household chores and asked to participate in sports to channelize his energy, and some extra time decrease workload. Small assignments should be given to the child. The parents must be taught to not be very critical about his behavior, and they should have patience and persistence with all of this environmental changes that has to be made in the child's environment. Thank you.
Now I would like to hand over the mic to sir and ma'am for the further question answer and the discussion.
So, Dr.
Over.
Saluni, you have nicely presented and concise with the concise history and the mental status examination, and also very nicely formulated diagnostic formulation.
Thank you, sir.
So, as per your history, you said he was apart from his attentional deficits, he was poor in mathematics and writing skills.
Yes, sir.
So, would you like to further investigate that part of his history to rule out any learning disability or learning disorder?
Yes, sir. On MSc, I had given him some writing sample, and also given him simple and complex maths calculation, which he was able to perform well in. And the spelling mistakes were also not there, while the punctuations were also proper in the writing sample. While reading also, there was a good comprehension of whatever he was reading, and there was not any pronunciation difficulties also. So based on that, I had ruled out any learning disability. Because the frequent spelling mistakes or the careless silly mistakes that he makes is due to, I would say, the factor of inattention, as he rushes too much while writing also. So that's why his scores have come down due to the illness itself.
Oh, and what other assessments would you like to do for ADHD to confirm your diagnosis?
Sir, first of all, I would like to give a rating scale to the parents also and to the teachers also. The rating scale that we use in ROPD is Conners. We give it to the parents and the teacher, ask them to fill it, and then we scale it regarding how much is the inattention, the hyperactivity, and the impulsivity part. So in that way, and if all of the symptoms are present in two settings of the school and the home. Also, there should the maximum of 6 criteria in both should be fulfilled, especially before the age of 12 years. Then we can confirm that the diagnosis is ADHD.
And had you sought any information from the school regarding his behavior?
Sir, actually, the school had sent a school letter. So in the school letter, it was mentioned that he is not able to concentrate. He's being mischievous at the school. He frequently changes benches and runs to other benches in the school. He talks he back answers the teachers, and he also is verbally abusive towards other students in the class. So all of this was mentioned in the school letter.
Okay.
Yes.
So, what are the comorbidities which are associated with ADHD? Not in this case, in general.
In general, sir, there could be specific learning disability. There could be depression, anxiety, oppositional defiant disorder, or conduct disorder. There could be psychosis and any substance use history and tics.
And when you discuss the treatment plan with your parents, what was the reaction?
Sir, first of all, I helped them explain कि मतलब ये जो हाइपर एक्टिविटी है ये किस वजह से हो रहा है, why is he built like that, or why is all of this happening. So the mother was like, she herself is a teacher, so she was able to understand that what the problem with the kid is. And when I explained the mother about the medicines also, they were willing to give him the medications, because of the inattention. I explained ki because of the inattention he is able to perform poor in academics. Otherwise, overall he does not have any difficulty in comprehension or any solving skills. So the mother understood that pretty well, and then she also took a prescription of methylphenidate that we had started the patient.
What baseline investigations or examination you would like to do in this case before starting methylphenidate?
Sir, in the OPD, I measured his BP, I measured the pulse rate, and also we measured the height and weight, and we calculated the BMI. Other investigations like the baseline investigation, like complete blood count or liver function test, renal function test, serum electrolytes, blood glucose levels, we could send. Routine ECG is not indicated, but we could get a routine ECG, or we could get an ECG done for him, and would make them follow up with this particular reports.
And how would you like to go about the titration of methylphenidate in future?
Sorry, sir.
You said you start with we'll start with 5 mg of methylphenidate. How
Yes.
will you do the dose titration further?
First, sir, I would start him on 5 mg of methylphenidate and call him after a week. After seeing that the patient is tolerating well the methylphenidate, that there is no agitation, increased irritability, there are no sleep disturbances or decreased appetite, then I would like to further titrate it to 10 mg. And methylphenidate is given as 1 mg per kg. So currently his weight was 38 kgs. So depending on the response of the patient and the response of the symptoms also, then I would like to, depending on the weight of the patient, I would like to titrate it.
Okay. Thank you for your presentation, and you did well. And I like to hand it over to Dr. Naik Madam for further.
Yes. Thank you, Dr. Nishikant. Dr. Saloni, you have presented it well. I think because of time limit, you could not give us more information. Okay. What is the mechanism of action of methylphenidate?
Ma'am, methylphenidate blocks dopamine receptor transport uptake and norepinephrine reuptake, especially in the prefrontal cortex, because it's seen that there is a dopamine and norepinephrine deficiency in the prefrontal cortex. If it is made at a level that is sufficient, so the patient will be able to have attention and the hyperactivity will reduce.
Why did you choose methylphenidate? Why not atomoxetine?
Ma'am, because since methylphenidate is the first line drug that has been given in the guidelines also, and since there is no history of any seizure disorder, no history of any psychiatric comorbidities in the patient and in the family, there is no history of cardiac illness in the family that was diagnosed before the age of 40 years, no history of seizure disorder in the family itself, that's why I would like to start him on methylphenidate.
Did you rule out absent seizure in this patient?
Yes, ma'am. The mother did not report any seizure disorder history.
She may not get GTCS, but other seizure like an absent seizure, very common. So you tend to mistaken it for the inattention. So ideally, like EEG is required in this such patient because you are going to start on stimulant drug. Okay.
Yes, ma'am.
Second thing, you said like there is no family history of any cardiac disorder, so you will not do means ECG. I mean, so you need to rule out any valvular heart diseases. So ideally, even the echo is indicated before you start patient on a methylphenidate. And of course, you need to monitor the patient. How you are going to monitor throughout your therapy? How are you going to at each visit? What are you going to look for?
Ma'am, until the dose is being titrated, we have to call the patient on close follow-ups of 1 week. And after that, when the titration is stopped, like the patient is well maintained on whatever dose there is. So then for weight and height, that is the BMI, we have to call patient every 3 months. Also we can like see if there is any growth retardation. Then BP and pulse also can be monitored every 3 months.
So how long you are going to continue this? The therapy, how long you are going to continue? He's 12 years, no? So how
Yes.
long you are going to continue?
Ma'am, actually, we can see because if the parents are really concerned about the medications, or if they want to stop the medications, then we can see in the vacation when the patient does not have a lot to focus for. So then we can see and stop the medications. If the patient is able to perform well in daily activities of living also, like if the hyperactivity has reduced to a very significant extent, there is attention. He does not have to be called out many times. If he's keeping his things in a proper way, like if the environmental modification is helping him, then we can see ki, do we have to restart the medication? Otherwise we can stop the medication. We can see if the holiday stopping helps.
So what symptom is likely to see in the adulthood in this type of patients?
Inattention, ma'am, usually continues in adult ADHD, whereas hyperactivity reduces a lot, but there is seen that there is some kind of inner restlessness that is always present. So the adult might also be very anxious because of that.
Okay, thank you.
Thank you, ma'am.
Thank you so much, Shubham and Saloni. And thanks to our faculty for such a valuable insights and for the interactions and the discussion part. To summarize, the case 1 was about the severe alcohol dependence presented with acute alcohol withdrawal with complicated by delirium and following fracture and fall, and with management including the symptom-triggered lorazepam regimen along with anti-craving such as acamprosate was used, with motivational interviewing and psychosocial support addressing the holistic and multidisciplinary treatment approach. And in case 2, it was about a case of attention deficit hyperactivity disorder with symptoms of inattention, hyperactivity, and impulsivity, and with great insight on pharmacological management as well as the psychosocial interventions. Thank you so much for such a clear, well-structured presentation. It was very concise and comprehensive. And at the same time, it was a great learning session for all of us.
Thank you, ma'am.
Now, one second. Now, I would like to show you at the end the summary of how a short case presentation goes. So first of all, the history taking should be brief and concise. Secondly, the MSc should be detailed and all the verbatim should be included. And all the sequence should be in a very chronological order. And the physical examination should also be should be done in a detail and should be to a time limit. 1 second, sir. So our directed history focused on the presenting problem, full MSc in order, brief relevant physical examination, formulation using 4P model, and differentials and management plan to be ready before entering for the Viva. Coming to the last, at the end of the session, thank you, Dr. K.K. Mishra, sir, for taking out his precious time for joining with us. A sincere thank you to Dr. Sushil Gawande, sir, for his unwavering support and steady guidance. We are grateful, sir. Thank you so much, Naina Naik ma'am and Nishikant Thorat, sir, for taking out your valuable time and providing great insights into the short case exam pattern, presentation and discussion. And a huge thanks to all the students for their presence and making the session interesting and interactive. As we reach to the end of the session, we close this session with genuine appreciation for the depth of insight shared by our faculty and the curiosity demonstrated by students. May the ideas exchanged here find their way into our work and reflections ahead.
Thank you, Dr. Smriti, and thank you, Dr. Naik Madam, for being there for this interesting session on the Sunday. And congratulations to Sushil for regularly conducting this kind of a series for PG students, and I hope in future it is going to benefit all the PG students from West Zone. Once again, thanks for inviting me to be part of this activity, and wish you all the best. Thank you.
Thank you. Thank you, Nishikant. Thank you so much.
I would like to thank Dr. Sushil sir for inviting me on this platform, and Dr. Smriti, and thank you, Dr. Nishikant, and thank you all the students for your participation. Thank you.
Yes. Yes. 67 students joined, and it's a good number. So with our interactions, we could reach out to 67 students. It's really great. So thank you to both of you, ma'am and Nishikant. Thank you so much.